stories, science, siloed information. What does COVID-19 look like through the lens of an ICU provider? What are those stories, the science, the impact of the siloed information? That is what we'll work to unpack here. Hello and welcome to the Jefferson Educational Society's digital programming. I'm Ben Spagan, I'm the Vice President at the JES, and I'm a contributing editor at the Erie Reader. Our guest, Dr. John Evankovich, is an assistant professor of medicine in the Division of Pulmonary, Allergy, and Critical Care Medicine at the University of Pittsburgh, where he researches the Acute Respiratory Distress Syndrome, ARDS, and is a practicing critical care physician. In this JES digital program, Dr. Evankovich will discuss working in COVID intensive care units and how experiences for both providers and patients changed and are changing in response to the pandemic. We'll also discuss how rapid scientific advancement to combat SARS-CoV-2 was made possible by modern information ecosystem, but also how the pollution of that same ecosystem with COVID disinformation and misinformation has caused and continues to cause real-world harm. Now, Dr. Evankovich studies the molecular biology of lung injury. His laboratory is interested in the intersection of three molecular systems in the innate immune system and how they influence inflammation and cell death pathways in the lung. Now, teaming up with the Small Molecular Therapeutics Center, Dr. Evankovich's work aims to discover novel small molecular molecules to disrupt these pathways and to test preclinical models of lung injury. He is also an associate member of the Aging Institute, where he focuses on the contribution of aging to innate immune responses in the lung. He received his bachelor's in biotechnology and biology from Gannon University, moving on to receive his MD from the University of Pittsburgh School of Medicine in 2012. Dr. Evankovich got his residency training in internal medicine at the University of Pittsburgh School of Medicine, becoming a fellow in pulmonary, allergy, and critical care medicine at the University of Pittsburgh School of Medicine in 2018. Dr. Evankovich has published several works, and in 2020, he co-published Toll-like receptor 8 stability is regulated by ring finger 216 in response to circulating microRNAs in the American Journal of Respiratory Cell and Molecular Biology. For a fuller bio, full of all of his accomplishments, please do visit our website, jeserie.org, and the University of Pittsburgh Department of Medicine's website at dom.pitt.edu. Now, since this program is first airing live on the JES Facebook page, we're going to work our way through as many questions from you, the viewers, as we can as we host this event. If you have a question, just leave it in the comments section below. If you're listening to or watching a later broadcast of this program, still send us your questions, your comments to keep this conversation going. And for more information about upcoming JES programs and publications, visit that website, jeserie.org, and be sure to like us on Facebook, follow us on Twitter and Instagram, and subscribe to our YouTube channel. It is my absolute pleasure to welcome back a friend of mine from a long time ago, but to welcome him the first time to the JES digital stage, Dr. John Evankovich. Dr. Evankovich, thanks for joining us for this conversation. Can't wait for your presentation.
Great. Thanks, Ben. Thanks so much. Thanks for the invitation to share this. Thanks to the Jefferson Educational Society. I'm really excited to talk today with your audience and take questions just about exactly what you said. Kind of my perspectives being an ICU provider over the past year, much of that time spent in ICUs caring for people with COVID, but also some of the science that I do really think is going to get us out of this. And so hopefully part of the presentation today is going to be talking about those things and hopefully communicating, at least my confidence and my colleagues' confidence in, exactly how amazing these new vaccines are and how getting those out to people is really the next step for this to be done. So just to start, I'd like to just go over the three things that we're going to talk about. First is the acute respiratory distress syndrome, and this is basically a syndrome of lung injury, and why people that have acute respiratory syndrome, distress syndrome, really need to be cared for in the ICU, and kind of what that involves, both from the perspective of the providers, but also families, caregivers, and other people involved in that person's life. We're going to talk about some of the outstanding and amazing pace of science that basically this pandemic has brought on. And just as a first statistic, we have roughly over 126,000 peer-reviewed scientific publications in the past year on this, which is just absolutely mind-blowing and astounding. And some of that science, basically kind of the culmination of all of that science could be really the way that we get out of this. And then lastly, it's such an incredible thing to think about that kind of humanity was able to churn out all of that information and start toward the process of basically changing from a pandemic life to a post-pandemic life, but also how in that process the same technological advances, the platforms, the way we both share and consume information can be polluted by misinformation, disinformation, and really what I think is a larger question beyond COVID-19 about the information economy and how we and how society consumes information. I do also just want to acknowledge that this has been a very difficult year for everyone, and I certainly know that. And I think if you're listening in or you're watching this online, it's just worth saying that out loud. I'm not sure that we give ourselves enough time and space to really think about that. I would much rather be giving this talk in a space with everybody there, but that's not happening. As this moves on and goes on, we kind of yearn to get back to that, and I think it will happen. I also want to acknowledge that there may be people listening or tuning into this that have lost family members, friends, colleagues, or have been affected by this in a direct way with someone that was sick or sick themselves and recovered, but also all of the other peripheral effects and how they've kind of changed the way everybody lives. And I just think that saying that again is important to do. And I do really think that things are going to get better. As a healthcare provider, as somebody who was there alongside as this happened, I also want to say thank you to people. I want to say thank you to people that changed the way they did things, because those little individual behavior changes really added up to collective action that really prevented a lot of suffering and a lot of death. So even though things might, we talk about the things that went wrong or things that could have been better, it could have been a lot worse if people didn't buy into some of these things. So what is acute respiratory distress syndrome? We're going to just take a look at a picture. The first is it's a chest x-ray. This is what a normal chest x-ray looks like. And the main thing to look at here is that things that are solid are white and kind of the x-ray can't penetrate. So you have things like the spine, your vertebrae in your spine here that are very dark, and all the organs in your abdomen. So the x-ray can't really penetrate it. And the main thing is that the lungs here are very dark. They're filled with air. So that's what a normal lung should look like when you take a picture of it with an x-ray. In acute respiratory distress syndrome, what we see is basically very different from that. So we see a whole bunch of white in the spaces where air is supposed to be. And what that correlates to on a microscopic level is that the air sacs that exchange oxygen from the outside environment and expel carbon dioxide from our blood are actually filled with something, either fluid or the little units are collapsed. So these little lung units that exchange oxygen and carbon dioxide, they're clogged up, they're injured, they're filled with fluid, and they're no longer able to exchange oxygen and carbon dioxide. And that's really the basis for acute respiratory distress syndrome and why people that have severe lung injury end up in the hospital, end up on oxygen, and then sometimes end up in the intensive care unit. This is just a table that we use clinically to basically judge whether or not somebody has ARDS. And it's not really important to go through the details of this, but just to say that it's a spectrum of disease. And we don't have a test that gives us a yes/no answer. There's no light switch to say This person certainly, definitely, 100% has it. This person does not. It exists on a spectrum, and we measure that with things that we can take from the blood and measure how much oxygen is in the blood versus how much we're giving them. But needless to say, it's a severe lung injury, and then oxygen and carbon dioxide exchange are severely impaired. This is a graphic that looks at like the most smallest unit of the lung, the alveoli, and this is actually where all the action happens. So air from the outside environment comes in here and is exchanged across these membranes into your blood. Then your products of cellular respiration, which ends up being carbon dioxide, are expelled across these same membranes. So in a way, the alveoli blood interface is where oxygen gets taken in from the environment and where the products of your cellular metabolism are expelled. In ARDS, there's a lot of inflammation in those regions. So what we see with COVID-19 pneumonia, what we see with influenza, even though there are some direct cytopathological changes that occur with different viruses, different infections, one of the common things, or one of the uniting things across the board with ARDS, is that there's a lot of inflammation here. So even an air sac that's not directly infected with COVID-19 virus or any other type of injury can still be injured and not exchange oxygen because there's lots of inflammation there. And I'm going to show you the one on the left and compare it to the one on the right. In early ARDS, there's a lot of inflammation, but as people heal and get better, sometimes with support of oxygen and therapies we do in the ICU, one of the consequences of any severe inflammatory injury is the propensity to form a scar. So we see this late in COVID. It's a fibrotic process. And I do think this is going to become more and more important as people recover from severe COVID. We may see that there is basically a long-term sequela of lung injury, being lung fibrosis, lung scarring. So those type of things are only really beginning to be unraveled. But needless to say, I do think there's going to be a subset of people who had severe lung injury who will potentially have kind of long-term effects from this. And to explain kind of the rationale for how we treat this or how we support a person through ARDS is to kind of look at this spectrum here. And on the left is that normal chest x-ray, on the right is full-blown ARDS. And as you move along that spectrum, the severity of lung injury increases. And as a treatment modality, we give different levels of oxygen. So there's all these different ways to deliver oxygen to people. And in general, they're lined up here along this axis based on how much you can give, right? So some of these ones here are just like a bigger fire hose. But as you get over into this area here, you get to where we're adding not only oxygen, but also pressure. We're pressurizing the lungs to pop open those little air sacs. And it's not really super important to know, what's what and the different nuances of these. But in general, people that need less oxygen are admitted to the hospital ward, okay, which is where most people think of being admitted to the hospital. That's where they are. And that's where you've got a team of people that are taking care of you just like anywhere else. But the number of people that take care of you there is less than in the ICU. In contrast, when a person is admitted to the intensive care unit, there are more people there per patient. And that's really the distinguishing characteristic between someone who's admitted to the hospital floor and someone who's admitted to the intensive care unit. So here we have basically just a more intensive resources, which is mostly people, to take care of a more severe injury. And you can see down here, this bottom one, intubation. This is the need to go on a mechanical ventilator. This means that a person is going to be sedated, and basically that the physicians and the care team are going to basically take over the breathing process for a person to be in charge of it, to get as much oxygen as we can. And so I just thought it would be kind of interesting for me to tell you all about just what my experience was like comparing kind of a pre-COVID year to a COVID year in the ICU, just to kind of put it in context, because I think some, looking at the numbers over and over again, it kind of what's the difference? It can become a little bit abstract in a way. But I'll just tell you, I'm one doctor. I don't work every single week in the ICU, but all of the time that I do work as a clinician is in the intensive care unit. And if I go back to 2019, and my time in the ICU, I remember 2 very sick people with influenza ARDS. And these are actually their pictures, but I'm putting those up to tell you that in the course of an ICU week for me personally, there could be anywhere from 0 to a few people with ARDS. And in particular, these 2 cases, I still remember very vividly. I remember, exactly how old they were. I remember their families. I remember talking to them. I remember talking to their families in person. I remember the things that happened along the way. So these things, like, I still remember those 2 cases from that year. And then if we contrast that to what it looked like this year for me, it was somewhere on the scale of 5 to 10 times what that was. So these aren't actual people that I took care of, but this is about 50 chest x-rays. And when I went back through my electronic medical record to look at just kind of how many people I had encountered and helped take care of over the course of basically October until now, this is what it was. And needless to say, it was quite different, but also, basically taking care of these of people with ARDS is extremely labor intensive. So this not only represented, a greater volume, but it represented an exponentially greater amount of work that was required by the entire care team in the hospital to take care of these people. So really just a big difference for me. And when people talked about the concern for hospitals being overflowed, this is really what I think they were talking about, is at least what I personally was worried about. And I'm glad that things are slowing down now. It's very, very good news for me. But not so much for me, but for the fact that now, with less people in the ICU with ARDS, that the healthcare providers, the doctors, are able to spend more time with people to take care of them. The next thing I wanted to show is just a couple graphics that I thought would be useful to look at in terms of, what are really the outcomes of people who get hospitalized with COVID. And I think there's a million statistics floating around. And we have a range of what we know, and we have in some places, maybe a difference by a few percentage points here or there, or based on, what time of the year it was. There could be some different numbers, but this graphic here is from basically a collection of hospitals that basically put all of their information into a registry with the Society of Critical Care Medicine. And it represents 20,000 patients that were hospitalized with COVID across the country. And I actually think this is an international registry. But I found this to be really important because it basically focused in on the people that were hospitalized. And then it stratified them by how much support they received. So of people that were hospitalized for COVID, the number of people that eventually died was about 8%. And we saw that number go up pretty dramatically based on whether or not they ended up needing some kind of invasive mechanical support, i.e. the ventilator. And then also whether or not, on top of COVID, there were other organ problems. So we see that with mechanical ventilation, the mortality was about 41%. When you added mechanical ventilation and an element of shock, where the blood pressure is very low, the mortality went up. And then we saw this phenomenon that we're well aware of in critical care, but it's when another organ is severely injured or fails, you add multi-organ failure into the equation. It becomes much more difficult for a person's physiological capacity to recover from that injury. The other striking thing about COVID, and I think this has been reported widely on, is that the outcomes vary very widely by age. And I think what I want to communicate is that this phenomenon most likely reflects this concept of physiological reserve. And this is also why comorbidities that have been identified that put people into a high risk category. It's not so much that those things in and of themselves make the infection worse, is that they interfere with the body's capacity to recover. So you think of the idea of physiological reserve like a gas tank, or you get so much reserve if you go on empty. The smaller that reserve is, the harder it is to kind of overcome an injury. And these numbers here are raw numbers for people that were hospitalized. But if you took these numbers and you only looked at people that were admitted to the ICU, you would at least double them. So meaning that if someone that's over 60 years old that comes into the intensive care unit, sick enough to come into the intensive care unit, mortality is somewhere in the range of 50 to 70% in our experience. So with that, the other thing that I think people talk about, and I'm not sure if people have seen this graph, I hope they have, and I've taken so many questions from patients and families about this in terms of like, how bad is it really? How could you compare this to other viruses that are out there, other types of lung injury? This is from the CDC, and they're basically mapping how much influenza is out there every year. And this basically shows this variation in the number of influenza cases that are diagnosed. And then this kind of yellow peak here is how many deaths from influenza there were over a given year. And you can see right at the end of the year, week 50 is when these deaths start to spike up. But you can see the past 4 years here are all way down here on this baseline. And when you look at what COVID has done over the past year, the area under this blue curve is just out of the stratosphere. So, this is like a supernova event, a concentration of all of this stuff happening at one time. And it really is something completely different. And from a numerical standpoint, just completely unprecedented. So with all that being said, I thought one of the things that I talk with very frequently about with people in the intensive care unit, families, patients themselves, this is a mandatory conversation that I have with people, and it's always asking folks whether or not they have advanced directives. Do you do advanced care planning? And I think that, as a critical care provider, this would be something that I would want to communicate with people for COVID-19, but really for anything at any time. And it's this idea of advanced care planning. And I think there are probably some misconceptions about it, or maybe the way people think about it is not the way I think about it. So I just thought I would tell people the way I think about it, and why, when you come into the hospital and a doctor, asks you or your loved one or your family member about this, where they're coming from and what they might be, asking about. So advanced care planning really is just about learning about the types of decisions that need to be made, considering those things ahead of time, and then letting people know, whether that's people in your family or your healthcare providers, about your preferences for medical care. And the reason it's important is because if that communication doesn't happen to the healthcare providers, a person might receive too few or too many interventions, both of which are not aligned with what they want, and it can impact the way that person is taken care of. So if you look nationally across the country, only about 1 in 3 people have documented advanced care directives. And I think that is discordant with the number of people who have talked about it with somebody. So if you look at this across a large scale, these publications are kind of here and cited, but really the majority of people, about 80 to 90%, have some type of conversation, usually with their family member, just about this kind of thing, about, if I was ever in this situation, this might be what I want, or, I would or would not want, this type of thing if it ever came to that. But the problem is that those really only get communicated to healthcare providers a fraction of the time, maybe like a third of the time. And it becomes difficult in those situations. So what I hope, and what, I think that other folks and other outlets have tried to do, is accumulate as much knowledge about this as we can to empower people to make decisions with their healthcare providers about the type of preferences they have for their own medical treatment. And it's to say that also that these discussions are not easy, and it's better to have them in a time and space where everybody has emotional space, time, and the cognitive capacity to do it. So if you're coming in to meet a critical care doctor, and this is the first time that a family is having this discussion, it can be much more challenging. It can add additional stress to the situation. So, we know that for patients and for family members, being critically ill is a traumatic event in and of itself. And one of the ways to minimize that trauma and to basically promote healing and recovery is to not have to worry about this in advance. Now, does this mean that once you put something down on paper that it's sealed forever? No, absolutely not. People's preferences change over the time. They change in response to a situation, but it's always so much better to have it at least thought of in advance. So just the last part about being in the ICU, I think some of the things that changed that were hard for my colleagues and all of the people at the bedside were the lack of family presence in the ICU. And this really changed things, because we know as critical care providers and as healthcare providers that the presence of family for critically ill people is actually, physiologically important. It reduces the amount of delirium and confusion people have. And, I can't tell you how many times a family member has told me something that has basically alerted the rest of the care team to something that we would not have picked up on that turned out to be really important to that person's care. This other part is communicating prognostic uncertainty. So even now, and even, especially in the beginning parts of this, there was so much uncertainty, so much we didn't know, so much we couldn't tell people, that it was hard to say that over and over again. We just don't know. We just don't know. And one of the things that, that I've done, and that I hope other providers have done, is be upfront about this, because I think the alternative in giving people some kind of false assurance or false narrative that says actually I'm certain about this in a time and a place where things are uncertain is dangerous. And also just recognizing that there's really a chain reaction of events that happens when somebody comes into the ICU with COVID, that this is something that is, happening to the patient, but also that there are so many complex family dynamics that are going on, and that with this contagious virus, a lot of times families were dealing kind of with their own outbreaks, or even having multiple family members sick at the same time. These are things that, we were not used to dealing with, and not used to kind of parsing out exactly how to make it all work. And then really this idea, and again, I'm going to say, again, this is going to get better, but historically, pandemics in general concentrate things that happen all the time. So what we've seen in the past year, unfortunately, is a concentration of all of this into a couple months. So maybe get a chance to move on to kind of our next topic here, and this is looking at just the outstanding, kind of amazing pace of scientific publications over the past year. 126,500 and counting is what I put on there. So I'm thinking back to a year ago in January, and I remember the first thing that that made me pay attention to, like, oh, what is this coronavirus thing, is seeing a video of a field hospital being built in Wuhan. And it was this drone footage of all of these construction vehicles making a field hospital. And I was like, wow, that looks really weird. And also, wow, that's a really big effort. Something really bad must be happening. And then by the end of that month, this was published in the New England Journal of Medicine, a novel coronavirus from patients with pneumonia in China, 2019. And this was in basically less than a month, 6 weeks-ish, that this report was, through peer review and published. And it showed some of the cytopathic changes that they observed in people's lungs, and also published these chest x-rays. And, at this point, when I saw this and I saw the ARDS, I said, oh man, like, because I knew that this meant that if people really got that sick, there was going to be a lot of people in the ICU. This publication has been cited over 6,000 times in a year. That's crazy. But it just goes to show you how much output there's been. Some of the technology that's made it possible to have these vaccines and to know what is going on has been the advances in sequencing. So the first genome was published or put up as a preprint on January 10th. And with that sequence, the people at the NIH and Pfizer started basically designing the mRNA vaccines, which are now, being rolled out. This is from January 29th in the journal The Lancet, and this publication lined up the different viral sequences compared to other coronaviruses that were pathogenic in the past. The original SARS genome, the MERS genome, the Middle Eastern respiratory virus, all of which were coronaviruses. Those two coronaviruses were kind of contained, eliminated from the population. But if you line up the sequences, you can see how different or how similar they are. And it turned out that SARS-CoV-2, the pathogenic virus, was very similar to those other ones, only off by a few key amino acids, a few key pieces of sequence. And it was because they were so similar to ones in the past, you could translate some of the knowledge that was gained from those prior pandemics and translate it into COVID-19. And so just the pace of this, absolutely outstanding. And then it was off to the races. This is a graph showing that what happened over the year in terms of how many publications you can find. And if you look at, like, it even depends on how you define what a COVID publication is, but the best estimate is somewhere around 126,500 as of last week. And just to put that into perspective, one of these places publishes a weekly report, and there were 2,300 publications in a week, 327 in a day. And that means that even if on my best day, you can't read less than 1% of all the stuff that's out there. So what I do is I trust that the academic journals that publish some of the big groundbreaking science are going to publish the big groundbreaking science for COVID, and those are the ones that I try to keep up with in addition to our own work. So just a very quick plug. I think this is one of the things that I'm most proud of over the year, and actually very proud of the people involved with this, the people that worked on this. This is our own lab's kind of contribution to the COVID literature. This is a preprint, so it's not fully peer reviewed yet. Fingers crossed, that it will be in a peer reviewed journal very soon. But throughout the year, as I was many times in the ICU, these team of scientists were in the lab doing this work. And to do this much work in a year in a non-pandemic situation is incredible, but to do it under these circumstances is even more astounding. And it's just also very humbling to think about all the work that went into this from this group of people, and to know that there are thousands, hundreds of thousands of people who work just as hard over the year as well. So basically, what we did is we looked at one of these cofactors on human lung cells that kind of like opens the door for the coronavirus to enter our cells. And we looked at some different compounds that are already clinically approved for other indications and asked whether or not those compounds might affect this one particular cofactor on our host, on our cells that allow this coronavirus in. We were able to identify two main ones, and in both cases, those drugs in a dish stopped basically a non-live pseudovirus from entering cells. So if you treated the cells with a drug, and then we basically gave the fragments of the virus, not live virus, but the fragments of the virus to the cells, it basically stopped those fragments from getting in. So, that's our contribution, and hopefully that will be published soon. But, quite an amazing process, and kudos to the whole research team who worked on that. I think the most important thing to highlight about the science are the vaccines. And what is so incredible is that we're here a year later and that people are getting vaccinated. This is a diagram of just how vaccine safety is evaluated. This is a well-established kind of pipeline. The thing to know about the mRNA vaccines is that they had actually been in development not for COVID-19, but for other indications for a long time. And over basically years and decades, scientists were refining ways to deliver these vaccines, how to store them, how to basically make them so that they were like going to work. And it happened that as soon as that genome was published, they started working on designing a vaccine that could be used for COVID-19. So the phase 2 trials were started almost right away. They were published in the early summer. By July, the phase 3 trials, which recruited 30 to 40,000 people in each trial, were underway. And then by late fall, we got the emergency use authorization for the vaccines. And right now we're probably close to about 40 million people in the US that have been vaccinated. And these are the two reports, and this is the primary source in the New England Journal of Medicine. The data that's in these articles was the same data that was submitted to the FDA. This vaccine is the Pfizer vaccine, and they include a nice little diagram here to show exactly how this works, that the vaccine really just is this little piece of messenger that is encapsulated with a lipid that allows it to diffuse into your cells. And then that message gets translated by the host cellular machinery to make the spike protein, which is the outer core of the coronavirus. Your own muscle cells present that spike protein on its surface, and then your immune system recognizes that as foreign and mounts an immune response. Once that immune response kind of matures and makes antibodies and gets your T cells ready to go, if in fact you did come in contact with COVID-19, then your immune system is already primed and ready to go, and that's how it works. So this is the actual data, and this is convincing to me. I mean, even without like looking exactly at the numbers, it's not a trick. This is basically showing that over time, people who received the vaccine were less likely to be diagnosed with COVID-19. And you hear these statistic about the efficacy of extremely high. But I do also think it's worth pointing out and being very honest that it doesn't completely protect people from being diagnosed with COVID. So even though people are vaccinated, they can still, catch the virus, be diagnosed positive with it. But the best part about it, and I think the thing that's really why I think this is going to get better and why I think that this is the way out of this, is that of people who were vaccinated, even if they did get COVID, none of the people in the trials got severe disease to the point where they needed to be hospitalized or come to the ICU. So if anything, it definitely reduces the severity of disease. This again is the New England Journal article with the Moderna vaccine. So really just amazing. And I, hope that people are looking at this and saying, this is why we're doing this. This is why, because it works. The last part of the talk, I just wanted to go through what I call siloed information. And it's this idea about how, this virus and global pandemic also caused an infodemic. So what is an infodemic? This is from the World Health Organization. And I just basically took text right from their site to explain, because I found that it's probably the best and most clear explanation of what an infodemic is, and then why I think it's important to talk about and what we can do about it. So by their definition, first saying that COVID-19 is the first pandemic in history where technology and social media are being used on a massive scale to keep people safe, informed, productive, and connected. At the same time, the technology that we rely on to keep connected enables the amplification that could undermine the global response and jeopardizes measures to control it. And really, at its most basic and simple form, an infodemic is just having an overabundance of information, both online and offline. And I kind of feel that way navigating the COVID scientific literature. It is overabundant. But you can also mix in deliberate attempts to disseminate wrong information, which could undermine public health responses, could advance alternative agendas to groups or individuals. So, on one hand, all of this wonderful science could be the way that this ends, but having polluted information can also be harmful to people's physical and mental health. The biggest message that I want to get across about this is that there can be real world consequences to consuming, sharing, and changing behavior based on bad polluted information. So misinformation does cost lives. Without the amount of trust in health institutions, all kinds of downstream effects, people not getting tested, and really people not getting vaccinated. So in those environments, we could see that the pandemic basically continues to go on because of this kind of misinformation. So the other problem is that it makes people more polarized. So you can basically exploit the fact that there's a knowledge gap. You can exploit the fact that there is uncertainty about something and use it to polarize people. I think that's wrong. And I want to get away from that. And I think, Ben, having things like this where we can have a conversation and talk is one way to do it, to dispel some of the things and to say, like, let's talk about this. So what's the difference between misinformation and disinformation? By and large, misinformation can be unintentional. It can be something that a person connects with either emotionally, or they see something and they have no reason to think it's not true, and they consume that. And even though they have no intent of it being wrong, or basically there's no intent behind it being harmful or wrong. That is in contrast to something like disinformation, which is intentional. So this is someone who is planting something that they know is wrong to exploit some other agenda, or to purposefully misinform people. And disinformation can be laundered into misinformation by unknowing people. And that's what I want to talk about next. So I think this is really interesting to me, and this basically kind of helped me think about just how I receive information. and my own biases in thinking about that. So, this is a graphic from a paper that was published in Nature Human Behavior, and it's called Assessing the Risks of Infodemics in Response to COVID-19. And if you look at this graphic, they distinguish between online things that humans and bots that are artificial and can amplify things. So the red are people who are basically sharing false content. These are people that make disinformation, and the kind of bots are artificial ways that you can amplify that. All right, so they start it, and that's in contrast to someone here who is a reliable news spreader. So this might be a fact-checking organization, someone who uses journalistic ethics and fact-checking to spread something that is reliable. And you see, like, the people in the middle, the blue dots are you and me and regular people that consume news. And if you look at this person here, D, they're getting their news from different sources of information, but both of them are red. So this person could be consuming news that is disinformation and not knowing it. And meanwhile, over here we have a person who's getting a little bit of a mix of both, of things that are reliable and fact checked and probably accurate, and things that are not accurate. But in that environment, it can be extremely disorienting to know what is what, which is which, who to trust, and what things are fact checkable and what are not. And I think that kind of disorientation is another thing that can be exploited to basically silo information. So what are some of the things that can be done to help this out? One is digital media literacy. So this is from the WHO, tips for navigating infodemic. So basically, this is just like being super careful about where the source is. What is it that you're sharing? Why are you sharing it? Can you look to see if it's manipulative? Is this something that's 5 years old that's not relevant anymore? And at the end, it says turn to fact checkers. And I think that's just a very good piece of advice. This little graphic here could very easily be a graph of how COVID-19 spreads from person to person, but it's basically mapping how some piece of false news could amplify on social media or otherwise. And just doing these little things here can stop the little transmission chains. And I think that's super important. But what is really the challenge? What are we up against? Well, we know that things that are demonstrably false spread online faster than things that are accurate. This was from 2018. It's a really complicated modeling of news stories to find out that this picture just shows that something that is false can be shared and spread out over a quicker time period than something that's accurate. And this was predicted to be a problem. This is from 2018, someone from the London School of Tropical Medicine, Dr. Larson, and who basically said that, if we ever get into a big viral pandemic, all this stuff that can pollute our information streams might be just as dangerous as the virus itself. And I think that in some ways has played out to have some truth to it, in that a lot of misinformation has hurt people. So how does this stuff actually go? And this is like so fascinating to me. It's outside, what I do every day. So this is from a professor, Dr. Johnson at George Washington University, and this was in a Nature article this year. But they basically mapped like some malicious content and showed, just like anything else, that it spread from platform to platform. So a lot of this kind of really nasty stuff originates in places that you wouldn't expect it. And this little blue part is the Facebook post. So you may see something online or shared from someone, have no idea where it comes from, but if you trace it back, it might be down here in the kind of really nasty dark web corners of the internet. And it gets basically laundered through these channels to make it to, kind of mainstream consumption. So it can be really challenging to figure out where that came from. One of the biggest case studies of this is the video from over the summer called Plandemic, and I hope, maybe people don't know what that was. That would be great if you did. It was this video that was 26 minutes long, and basically used every kind of conspiratorial thinking kind of playbook to really play on people's kind of feeling of being overwhelmed by the pandemic, not having a good answer for what was going on, being scared about the future, being uncomfortable, as we all were feeling, and used that to basically exploit those feelings to put out this thing about, you know, where the coronavirus came from, that masks were harmful, and just kind of all this other stuff that, you know, was just clearly not true, but also spread because it was so emotionally made such an emotional connection with people. And if you look at the word cloud from where this thing came from, it was from all the dark corners of the internet, even though most people saw it from, you know, their friend or someone from their family. That's not where it started. And, you know, I wonder if people knew where it came from, if they would have been as likely to kind of share it and to be, you know, to kind of pass it on. But, you know, that was taken down, it's gone. But I think that it's a good case study of how this stuff works, and, you know, how, you know, we can fact check it all the time, but if what we're up against is something different. So in the last couple minutes here, you know, this is from the same group looking at vaccines. This was from 2019, and this is a map basically of Facebook groups. And the closer these little dots are to each other, the more similar they are. And the red dots are pages that shared anti-vaccine sentiments, and the blue are groups that shared pro-vaccine sentiments. And the little lines that connect them are connections, either like sharing stuff on their page or like people, you know, talking to each other. And what you can see is that, you know, there's a whole bunch more of these pages, these green ones, which are kind of places or pages that don't really take a stance. There's a lot more of them that are in proximity to pages that share like an explicitly anti-vaccine view. But also more concerning to me is that these two are completely separate worlds. So, you know, a person could exist, you know, here in this dot or here in this dot, and be getting, you know, a whole bunch of information from places, and thinking and knowing like, hey, I'm a person who consumes information from a variety of sources. But if your variety of sources are just, you know, all the little nodes that connect here, you basically have two people living in almost like two different universes. And what this study showed, kind of, you know, concerningly, was that after an outbreak of measles, the number of anti-vaccine pages grew in size and number. So it was, you know, something bad happened, and then that was used to actually bring more people into kind of consuming this false narrative. This same group looked at what happened for COVID, and this is a preprint, but as you can see, kind of a similar trend. You've got kind of pro-vaccine pages here and anti-vaccine pages here. This is the start of COVID, and then over time, you know, those pages that were connected to the anti-vaccine kind of grew in number, and also these are very separate kind of communities. So I think this is really harmful, and I wish that there was a way that we could, you know, connect these two worlds in a rational kind of empathy-based way to start talking some of this out. And I will say that, you know, despite looking at that, you know, that's only one little corner. That's one study. That's social media. That's in that particular study was just on Facebook, but the large national surveys that are coming out now are showing very recently, just in the past couple of weeks, that as time goes on, you know, people in this country have become more willing to be vaccinated. I think that's a very positive thing. So I hope that the messaging is getting out there. I hope people are buying in, and I hope that, you know, we can craft a way to make that happen. And just the last thing here, what can be done, and this is something that I think is just really super important in this group of researchers here. I've learned so much from reading their work, and I'm so thankful that they put this out there, but these are people that really worked in climate change communication and basically boiled down traits of conspiratorial thinking. Exactly what are some of the tactics used by people who, number one, plant disinformation, and how they kind of use these traits to get buy-in. And I came across this as I was making this talk. I thought it was too good not to share. But this kind of idea. My middle school teacher yelled at me that Wikipedia wasn't a reliable source is sharing vaccine conspiracy theories on Facebook. So I think there's this myth that this happens to other people. This doesn't happen to anyone I know. This doesn't happen to me. That's not true. It can happen to anyone. It does happen to everybody. And I think we just need to be more aware of how these things work. So what are the 7 traits? And this is according to Dr. Cook. A lot of the things that are what I would say conspiratorial thinking, or this, malicious disinformation, they have one or several of these elements in them. They can be contradictory. They usually, play to this idea that there's some overriding suspicion about how things are working. They can basically claim that the people that they're talking about have some kind of nefarious intent about things. There's always something that, something has to be wrong. This can't be true because it's the official narrative. And then, there's these other parts of it basically saying, this isn't really that, if you're telling me that I'm sharing bad information or what I believe might not be accurate, it's not so much that it's disaccurate, but it's that you're persecuting me, and that I'm the person here that's the victim of this problem. And being immune to evidence. So really all the fact checking and debunking, doesn't really mean a thing, because that's not part of why the person believes what they believe. And then this kind of idea of being able to make connections that are not there, this kind of apophenia, reinterpreting randomness thing. So on this website, they go through some of these examples. And for COVID-19, one of them that came out, this is an example of overriding suspicion. The death count is up due to medical professionals being pressured by the state to count patients as COVID when they either do not know or tested negative. The state wants higher numbers to show the devastation of the virus. And it's kind of just saying like, hey, if that was really the case, there's, tens of thousands of healthcare professionals. Do you think that one of them would have come forward to say that this is wrong or unethical? Reinterpreting randomness, or kind of making cause and effect, causal relationships that don't exist. This was one of the things that people believed, that maybe 5G was related to the coronavirus. And the example that the Dr. Cook gives is, well, Baby Yoda was also introduced in 2019, so maybe there's a connection there too. So it's just saying that like the causation, the correlation does not equal causation, and people find meaning in things that can be random. So in summary, I think to wrap up here, I hope, talking about acute respiratory distress syndrome in the ICU, that we could see how hard it is, how severe it was, and maybe what it's like for people in the hospital who have had it, and kind of how all the downstream things that come with it, just the outstanding pace of science and where we're at with the mRNA vaccines, and then how at the same time talking about making sure information is accurate, that people are making decisions based on good information is super important. So that's all I have. Thank you so much. Thank you, Ben. And if people have questions, I'd be more than happy to chat.
Dr. John Evankovich, thank you for your work on the front lines. Thank you for sharing your insight, your perspective, your knowledge here with our audience today. We appreciate it. I know you're one of the busiest guys I know, and I appreciate you peeling away time today to be able to review that, go through that with our audience. So we are really grateful for that. Just a couple of questions here at the end. I don't want to hold you up any longer because, again, I really appreciate all that you're doing on the front lines and then helping share that beyond that with the audience here. And picking up off of that right there at the end, let's go there. Let's talk about the misinformation and disinformation. And I think, as you said, many of us have experienced this, that this is more common than perhaps we might have thought it would be initially. So recommendations when you're encountering a friend, a family member, a loved one sharing something on a social platform that is clearly misinformation or disinformation, what do you do? How do you recommend we engage with that to curb that? What is our treatment plan there?
Yeah, great question. The first is to say it's a work in progress for everybody. But I think what I've read and what I understand is that number one, a lot of times just saying, you have an instinct to say that's not right, or why would you think that? That is not the right way to approach it. So if you have a legitimate concern and you have a good relationship with that person, it's better to do it one-on-one or in a private message than kind of out in front of other people. The second thing is just to say, what's the source? Where did you get this from? Or like, did you check this source? Or, I browsed this particular website and there's a lot of stuff on there that seems implausible to me. And then the other thing is to kind of think beyond what the actual thing is, but to ask why. What is the connection here? Because what I learned in learning about this is that a lot of the stuff that gets shared is not about what it actually says. It's the emotional connection to that piece of information. So if you say, why did you share this? It might be like, well, do you really believe what it says? So some people say, well, I don't, but I'm really upset about the whole situation, and this seemed like this person seemed mad too. So we're on the same page. Or it could be something not related to the actual thing, but that actual thing can be the thing that causes harm.
Well, I think that points right to, any study of the rhetorical appeals, and that often, logos, logic, and knowledge is the least accessed by people because it can be tough, it can be challenging. Whereas, pathos, the emotion, we're emotional beings, we just connect to something, and I think that's sort of our processing it in real time. And the easeability of just sharing something out, just clicking a button and then pushing it on, not thinking how much we're spreading or what we're doing, that, we're not practicing safe precautions. And I think it's a testament to some platforms trying to put some guardrails in place. Do you want to read this article before you share it? Do you want to, access this before you promote it? I think that that's a step in the right direction, but I think certainly it takes that entire community like you're talking about, and that one-on-one engagement of, asking somebody, why share this, and have you checked the sources, and walking them through that, I think is super helpful in a time like this. I think too, I want to press you on how do we build that trust or rebuild that trust in the science community and in the scientific method. And I think there's a lot that you covered in there. And I think that, the fact that we see more people trusting disinformation or misinformation initially pushing it out than, actual facts. And then seeing too, I think it was Dr. Larson you cited, who had projected in 2018 what we're experiencing now. And I can't help but think that my initial reaction to that was, why didn't we listen more deeply, more intentionally, and observe that and be ready for it? So how do we rebuild that trust, and how do we get more attention to the scientific community that that's what we end up sharing and that's what we end up spreading?
Yeah, that's a really
It's a
tough.
$1 million question, right?
I honestly, I think that it's wrapped up in a much bigger question. You mentioned about guardrails on platforms, but I think clearly, hopefully, we are coming to a realization that the information economy, how people in this country and around the world receive information through what channels, how platforms and algorithms can either nudge that or maybe control that are much bigger questions. And the COVID-19 piece of that, I hope, is clear evidence on how it can be exploited. So I don't know if I have the real, big answer, but I think for rebuilding trust in science, it's to hopefully know that people are coming from a place of wanting to do the right thing for people. And I think that's the case for most scientists and public health officials and nurses and pharmacists and physicians and rest. Like, everybody is there to do right by the patient. And in terms of building trust in public institutions, that I think is a longer process, but it comes with transparency. It comes with, getting buy-in from people. So how do you do that? Well, I hope that by having this country vaccinated and seeing COVID hopefully go away, that will be a good step to say, hey, we did this. This is a positive thing. We're not trying to hide something. We're not being nefarious. This worked. I hope that does it.
And I think that directs me right to the Hippocratic Oath, the idea of taking no harm, that you're out there to do good in the care that you're giving to people in the pursuit of a better community overall, a healthier community, a community that is more well than it is sick, and that we're not out, that you're not out here, the scientific community is not out here to intentionally do harm. There are no nefarious intentions of somehow making us worse on the other side of this. We're trying to make our community better on the other side of this. And we're seeing those results with the vaccine, and then we're seeing that buy-in change. So I think it's working. More people changing their viewpoints of whether they will or will not take the vaccine or consider taking the vaccine as they can continue to see the rollout. One final question, and I'll let you go, Doctor. And you mentioned the overabundance of information, and I think that, one, we want to celebrate those 126,000 plus publications that came out in a year. Just groundbreaking, just astronomical in terms of the output by the scientific community in peer-reviewed studies, peer-reviewed articles. But as we're dealing with that overabundance of trying to get that information and then process it and make sense of it, where do you point people? The places that we can trust, the places that we can go to make sense of as we try to digest what we can and not gorge on the information. So where do you recommend we go to for more information, aside from this talk, of course?
Yeah, thanks. I just want to also say one thing about our prior question. And I think I just want to say that the medical professionals, medical community, all of us also need to have an acknowledgement and even a reckoning of the fact that there have been some past harms. We need to take responsibility for that. We need to acknowledge it, and we need to pledge to do better. We can always do better, and we should be doing better. So I think that's also part of the picture. The trust for any type of relationship is earned. And I do think that for some communities, for some people, that trust was broken. So what do we do to restore that trust? It's a big thing. So it needs to be earned. And to your question about sources of information, I mean, I think the basic thing is that the sources that practice fact checking, that have kind of journalistic ethics to say, we're going to fact check this. And, I think a lot of those media outlets are legacy media outlets. They're known to be more reliable because they fact check. Whereas a lot of kind of online platforms that exist for a smaller audience or exist for not an audience at all, but just to rake in ad revenue, do not fact check. So knowing which one is which is really tough. The CDC website is getting better all the time. There's all kinds of data on there. I found the health publication Stat News to be an incredibly wonderful resource of science, journalism, and communication. And then both Science, the Scientific Journal, and Nature, they're the two kind of biggest scientific publications. They have their own journalism arms, which are free to read. And I think the quality of information on those sites is like it's like top notch. And some of those graphics I put in there are from those websites. So generally, I think those are the type of things that are reliable.
I think the key thing there being fact checking, make sure you know where it's coming from. And I think that reminds me of that great graphic that you had mapping the spread of fact checked information and disinformation, misinformation, and thinking not only are we up against people just sharing misinformation and disinformation, but I didn't see a representation of a bot out there sharing fact checked information. We're up against those trying to be disruptive in the conversation. So knowing where your information comes from, knowing that you can trust it and it's reliable, and knowing that it's not always going to be comfortable or make us feel necessarily better in the moment, but being more informed, I think that's the key takeaway. So Dr. John Evankovich, I don't want to keep you any longer. I know you've got a busy schedule, but I appreciate you. I appreciate your frontline service. I appreciate you sharing your insight, knowledge, and expertise with us here. What a wonderful job you do as an assistant professor of medicine in the Division of Pulmonary, Allergy, and Critical Care Medicine at the University of Pittsburgh, and as a practicing critical care physician. Again, thank you for your service. Thank you for taking the time to put this together, share this with our audience. Folks, we're so delighted to have you tuning in and partaking in this and being part of this discussion. We hope that you'll take something away from this and keep this conversation going in the spirit of good information and working toward that better outcome, those brighter days that we know are ahead. So Dr. John Evankovich, thank you so much for taking the time, energy, and effort to present today.
Absolutely. Thank you, Ben.
For folks looking to connect with you, follow along with your work, because you do have that study out there. It's under review now. Where could we point them to follow more of the work you're doing with the Department of Medicine at the University of Pittsburgh?
Yeah, the Twitter handle for our division is just PACCM @PAC.
Wonderful. We're going to point folks.
They highlight all of the great work that the pulmonary and critical care medicine folks do. So hopefully that our study will be up on that page at some point in the future.
Looking to celebrate that with you when it is, and welcome you back again for conversations. Always an open door here for you. We appreciate it. Also, more information at dom.pitt.edu. For more information about upcoming JES digital programming, please do visit our website, jeserie.org. There you're going to find videos of other past presentations available to stream on demand, as well as a whole range of publications, including reports, essays, and timely writings, as well as more information about upcoming JES digital events and more. And of course, be sure to like us on Facebook, follow us on Twitter and Instagram, and subscribe to our YouTube channel. For the Jefferson Educational Society, I'm Ben Spagan. Be safe, be sound, and thanks for listening and learning with us.